Hi everyone. In today's video, we'll be going through the process of appraising a medical paper. So why this is important? So when we are faced with a piece of medical literature, it is important that we are able to read through the paper and come to some form of assessment as to how relevant this paper is to the patients that we are treating and what conclusions can we draw ultimately from that piece of medical literature. So the purpose of today's video is to provide an outline for this process of appraising a paper. When it comes to certain details pertaining to certain specific studies or certain EBM concepts, we'll be covering them in detail in some of the subsequent videos. So this overview highlights the 5 key steps involved in appraising a paper. So we usually begin by asking ourselves why a particular study is performed in the first place. We then examine the PICO of the study and compare that against the patient of interest. We then look at the internal validity, which is ultimately an assessment of the robustness of the methodology of the study. We then review through the results or interpret it. And finally, we attempt to generalize and apply the findings of the study into a specific clinical context, which is usually the patient that we are treating. So when we ask ourselves why a study is being performed, we usually take a step back and ask what is already known about this specific topic. We also ask ourselves what are the existing gaps. And then when we look at the clinical question that is being answered in the study, we then seek to find whether or not some of these gaps may be addressed. So we then move on to assess the relevance or the importance of the clinical question that's being investigated. And this can be looked upon from a disease standpoint, where perhaps this is a new disease or the disease that's being studied has changing profiles. Could be from the standpoint of therapy, where there could be new emerging therapeutics or there could be new emerging evidence about existing therapy. From the patient factor point of view, sometimes there may be certain important subgroups that have yet to be studied in detail. An example would be many big RCTs are based off Western-based populations. And when it comes to understanding perhaps the disease profile in the Asian population, specific studies may be undertaken to address these questions. And oftentimes when the study is being performed, there has to be some degree of clinical equipoise, otherwise understood as some degree of uncertainty around the question that's being investigated. Because if, let's say, things are pretty certain, like for example, the use of antibiotics in the treatment of sepsis, if we are studying something like that, oftentimes there isn't much point. So there are instances such as questions where there have been conflicting evidence, or it may be in instances where therapy may still be fairly new and there has yet to be adequate evidence amounted to say that something is convincingly beneficial or not beneficial. We then move on to look at the PICO. So P stands for population, I for intervention, C for control, and O for outcome. When we look at the population, we want to spend some time looking at what's the constituent and what's the profile of this population. We look at demographic factors like the age, the race, the sex, the comorbidities of the patient profile, as well as the disease severity, and the clinical context. Is this a community setting, inpatient setting, or outpatient setting? And importantly, we then compare the study's PICO with the PICO of the patient of interest. And usually this would be the clinical context in which we operate in. And finally, when we attempt to generalize or apply it subsequently, we have to see whether or not the two PICOs align. Just a note on outcomes. So I thought it's worth highlighting some of these important concepts relevant to outcomes that are being studied. So a study may actually be a positive study, meaning that it may be statistically significant and the conclusions may say that this is a positive study. However, I think one of the important things is to actually scrutinize what are the outcomes that are being measured. Just because a study is statistically significant doesn't at the end of the day mean that it is relevant to patients. So two important concepts, the first being clinical endpoints versus surrogate endpoints. So ideally, we would like clinical outcomes. So examples will include that of mortality, morbidity, survival, and these usually have direct clinical relevance. However, we also do see instances where surrogate outcomes are used. So surrogate outcomes are oftentimes biomarkers that are used as a substitute to a clinical endpoint. And how this works is these biomarkers oftentimes have been shown to predict certain benefit or harm. And the advantage in using it is that some of these biomarkers may track disease progression more closely. And when compared to certain hard clinical outcomes like mortality, morbidity, these effects may actually be measured sooner. So from a statistical significance point of view, oftentimes, given that these measures can be measured earlier, it could be advantageous. But whether or not surrogate outcomes are clinically relevant, we have to take into account the entire context of the study and the context of the patient to make a judgment call on that matter. The second is that of composite outcomes. So composite outcomes are essentially a combination of clinical outcomes that are grouped collectively. They are advantageous in the sense that when the standalone outcomes, like let's say mortality, do not occur frequently, collating these various outcomes essentially increases the power of the study and increases the likelihood of achieving statistical significance. Limitations, however, would include that of if, let's say, there is a particular endpoint that is driving the statistical significance of the study, one might have to be cautious, especially in the context when that particular clinical outcome may not be of equal weightage or importance compared to the rest. So for example, we often see instances where mortality is grouped with MACE events, and within MACE events, you may have events like hospitalization for heart failure. But one might argue that mortality versus the latter outcome of hospitalization for heart failure would differ fairly significantly in terms of clinical significance. Hence, it is important to pay attention to some of these nuances when looking at the outcomes. So next, after we compare the PICOs of the respective studies, we then look at the internal validity. So the internal validity is essentially an examination of the methodology of the study. So why this is important is because no matter how relevant the study is and no matter how significant the results may be, if let's say the study is poorly conducted, then one would have to question the integrity and the believability of the study. So as you can see in this table, this table basically highlights some of the important points relevant to the different types of studies. When it comes to systematic reviews and meta-analysis, the focus is usually on evaluating the conduct and that process of the systematic review and meta-analysis. So we usually look at the different steps and assess whether or not it is conducted properly and whether or not that entire process is reproducible. While within that, there is actually a risk of bias assessment that actually sort of looks at the individual studies that are being assessed and whether or not they are internally robust as well. Then we shift gears and take a look at randomized control trials, otherwise known as RCTs, or cohort and case control studies, which are usually observational studies. As you can see, the factors that we tend to scrutinize tend to differ between an experimental study and an observational study because of the fundamental differences in the nature of studies. So for example, in randomized control trials, we oftentimes pay attention to randomization. How was it done? We look at factors like whether blinding was conducted, and we also look at the analysis method, whether it's intention to treat or per protocol. The details around these we'll be going through in the RCT talk. On the other hand, when we look at cohort studies or case control studies, one of the big problems that we are usually faced with is that of confounding. So confounding is a problem that results because we are not able to conduct randomization in these studies, and the conclusions that are drawn from the study may be affected by this problem of confounding, which will be explained also in some of the subsequent lectures. At the end of the day, when we look at cohort studies and case control studies, and when we compare a treatment and a control group, we have to assess whether or not confounding is adequately controlled for, and whether or not we can compare adequately across the two respective groups. So we then next look at results. So usually when we look at a study, there's usually primary outcomes and secondary outcomes. Primary outcomes are usually the main results that, or rather the main outcomes that a study seeks to study, and secondary outcomes are additional analysis and additional sort of data points that are being looked at. Typically speaking, in the context of a randomized control trial, the primary outcome is what the RCT is usually powered to answer a specific question, and hence the statistical significance is usually rendered in that particular context. So I think also when we look at results, another important point is also actually to look at the type of study that is being done. So whether this is a meta-analysis, whether this is an RCT, whether this is an observational study. And why it is important is because a study that is statistically significant, let's say in the context of an RCT versus one that is statistically significant in the context of, let's say, an observational study, just by mere virtue of the hierarchy of evidence, we would then tend to perhaps take the RCT study more seriously, of course, assuming that the factors of internal validity are not problematic. So when we look at the primary outcome, if let's say the result is statistically significant, we do not stop there. We have to ask ourselves a few other questions. So first is, what's the point estimate? And usually this is a question of what's the effect size of a certain treatment, right? Does it reduce the outcome by 5%, 10%, 100%? We also look at how precise the results are. So if let's say the confidence interval is very wide, what this might mean is that the results are likely to, the actual result is likely to fall within a wide range, and hence the confidence that we have in where that true point estimate is will be less confident in that context. And ultimately, we also have to make a judgment call of whether a result is clinically significant. So for example, you may have a treatment that lowers blood pressure by 1 mmHg, and that's statistically significant, but is it clinically relevant or significant? Let's say versus another treatment that reduces blood pressure by 10 mmHg. Once again, this involves some subjectivity and a judgment call, taking into account the therapeutic profile as well as the disease profile. And if let's say a certain study was not statistically significant, particularly in the context of a randomized control trial, I think one also has to be cautious not to immediately discard the study and think that it is negative and that there is no value to it. We also have to look at other factors like whether or not the study is adequately powered. We'll be talking about looking at power calculation in the RCT talk, but this is something important to bear in mind, because if a study is inadequately powered and if let's say it is not statistically significant, the next step may be actually to consider the conduct of a larger study that may then achieve statistical significance. Apart from that, we also look at whether there's any signal of effect in either the direction of harm or benefit. And ultimately also we then make the judgment call of what's the clinical significance and how do we apply the results even if let's say they are not statistically significant. For secondary outcomes, so especially so in the context of a randomized control trial, but generally in all other studies, when we see this whole host of other outcomes that are being reported, I think even if they are reported as statistically significant, one has to be cautious because number one, these are usually intended to be hypothesis generating, meaning that it's not the main question that's being looked at. And secondly, when one actually conducts multiple analysis, just by mere virtue of statistical probability, the more one actually tests, the more likely it is for a statistically significant result to occur. So especially if we see that there are many secondary outcomes that are being evaluated, one has to be cautious about problems like data wrangling, where one may be just trying to perform various analysis to get a statistically significant result. On this particular slide, I just wanted to highlight the importance of paying attention to what the outcome measure is being studied. So specifically looking at the concept of absolute risk reduction versus the concept of relative risk reduction. As we can see in this example here, where in the left side, which is the control group, there were 4 outcomes that happened out of 100 individuals, and on the right side, in the experimental group, there are 2 outcomes out of 100. So if we look at the absolute risk reduction, this is actually that of 2%, so 4% minus 2%. But the relative risk reduction is actually 50%, because 2 over 4 is actually half, right? So when just numerically looking at 2% versus 50%, the numerical perspective is actually very vastly different when one hears these numbers, although they are actually reporting the same thing at the end of the day. So it is important for one to actually be mindful of the type of statistics that are being used, and not be swayed or be biased into thinking that just because the number is large, that necessarily that the clinical benefit is very vast. And another important concept is that of the numbers needed to treat. So numerically, this is 1 divided by the absolute risk reduction. And this basically signifies the number of patients that need to be treated to prevent 1 additional outcome over a pre-specified period of time. And oftentimes we look at the numbers needed to treat to sort of make that assessment as to what's the sort of risk-benefit profile of a certain treatment. And once again, what's a good number needed to treat is oftentimes subjective. One has to look at the treatment, the disease at hand, and what is the outcome that's being measured. So we finally look at generalizability and application, which is ultimately the aim of evaluating any study. So we began by first asking ourselves why a study is being undertaken and ensuring that it is of clinical relevance. We then look at the PICO of the study and compare it against the population of interest. We then looked at the internal validity, where we basically assess whether or not the methodology of the study is robust. And then we look at the results and make an interpretation of what the results say. So then we come to the point of trying to apply the study to the patient before us, and a useful sieve to use would be that of SCRAP, where we consider the sex, the comorbidity, race, age, and pathology factors of the study, comparing it against our population. The more closely these line up, the more likely that the study at hand would be relevant to the patients. And finally, when we want to use the study to inform us about clinical decisions relevant to the patient before us, we have to take a step back and ask ourselves how the study may add to the existing body of evidence. Do they corroborate? Do they go against the existing evidence? And if so, what may be biologically plausible explanations? But it's also important to ask ourselves what the study before us does not inform us about. So just because the study says that, because it's statistically significant, there's a certain benefit, and therefore this treatment has to be used for the subsequent patient. Apart from looking at all the other factors as mentioned above, we also have to take a step back and just go back into the clinical context and ask ourselves what other factors may be relevant in that clinical decision before us. And finally, when we look at this study before us, we look at the existing body of evidence. It is also important to think through what might be future useful studies, what are existing gaps that exist. And in doing so, we would have a better understanding of the question before us, as well as furthering treatment for our patients in future. So I hope that you found this summary of appraising a paper helpful.